It's time for the Q&A. I got my tripod's broken, and so my phone is gradually dropping. For once, Instagram is not Instagram, Facebook, but that's right, isn't it? Oh God. Hi Jackie. I don't know what's happened. I think I've over tightened the tripod and the bits. Anyway, we'll see how we get on. Hopefully everything's working, audio and video. Don't even know how I test audio. 2121. Is audio working? Are we live? We are live on Facebook and YouTube, I believe. Corinne and Jackie are here, so then the party can start. So been a couple of weeks. 2 weeks ago I was doing an operation, wasn't I? And I finished late. And last week I was at the BARPS meeting. God, was that a week ago? Crumbs, that seems like yesterday. In London, and they let me promote my book, which is great. Your book, you're saying not Never Accept a Lift from Strangers. Not that book, guys. They let me promote this book, Mind Your Own Business. Oh, what was that saying? Not for resale. Anyway, yeah. This guy's got 2 books. Yeah. So Mind Your Own Business, my new book. It's for doctors, really. How to turn your medical practice into a business rather than just a job. The Pecan Approach. Congratulations on the book launch. Thank you, Corinne. I'm not sure if I call it a book launch, but anyway, yeah. You know, onwards and upwards. Always. You know, we're all in the gutter, but some of us are looking to the stars, and that is certainly me. So, if you've got a question, just ask away. Currently, it's just you and Corinne, Jackie and Corinne at the moment. So, if either of you got a question, then please ask away. But, you know, never know, someone else might join in due course. But it doesn't matter. I got questions to answer. So, you know, sit back, relax. Let's do the questions that I've got, shall we? What is the difference between a hypertrophic and a keloid? This is it. I haven't been here for 2 weeks, so everyone forgets today. Is that it? It's consistency is important. And I couldn't have done it last week. At the BARPS. Week before I could have done it, I suppose, but I was so tired after the op and everything. Anyway, I'm here. I'm back now. What's happening next week? But anyway, back on the horse, as it were. What's the difference between a hypertrophic and a keloid scar? So this is a problem this day and age. Patients get so involved in stuff. I'm not saying it's bad, but it does lead to questions like this. What's the difference between a hypertrophic and a keloid scar? Because I think a patient said something and I said something about a keloid scar, and then they came back and said it's not a keloid scar, it's a hypertrophic scar. And I thought, right, okay, yeah, fair dues. But at the end of the day, it doesn't matter, is the answer to patients. If you're a patient and you've got a lumpy, ugly scar, that matters. The difference between a hypertrophic and a keloid scar is academic in a way, meaning it's for, you know, the doctors, and when we do exams and things, we're examined on the difference. But basically, they're both lumpy scarring. There's a bit of debate. If you want, I'm going to answer the question. Don't worry. So there's a bit of a debate as to whether they are separate entities or whether it's part of a spectrum from normal scarring up to keloid scarring, and then on the way is hypertrophic scarring. I've got to be honest, I would probably go with that. I think they probably are a spectrum. On a spectrum, some would say that keloid scarring is a separate entity. So, and the difference being that they're both red, firm, raised scarring that can be unsightly. A keloid scar is a worse version, and the main difference is that a keloid scar will extend out with the boundaries of the original scar. So a hypertrophic scar is normally a scar in the same sort of linear or whatever, and a raised thing. A keloid scar can grow really huge, much bigger than the original scar, almost like a cancer. And a keloid scar is often genetic. A keloid scar is often in certain skin types, Afro-Caribbean skin types, and is very difficult. Well, they're both quite difficult to treat. A an keloid scar doesn't get better. A hypertrophic scar tends to be self-limiting. A hypertrophic scar is usually within the boundaries of the original scar, although very red and raised. And a hypertrophic scar is often secondary to delayed healing. So certainly if there's been more than 3 weeks of healing, if the wound has taken more than 3 weeks to heal, then that would predispose to potential hypertrophic scarring, which is one of the reasons why if you have a burn, we will often assess it at a week, sort of a week to 2 weeks, to see whether it's likely to heal within those first 2 to 3 weeks, because if it heals within the first 3 weeks, then it's less likely to form hypertrophic scarring. So that would be a reason to skin graft someone. If we thought the burn was going to take a long time to heal, we would skin graft them rather than letting it take more than 3 weeks to heal. So that's why one of the reasons why we will assess a burn, have a look at it. Sometimes it's barn door, full thickness, obvious burn, but sometimes it's what we call deep dermal, which is quite a lot of the skin has been burnt, but not the whole full thickness of the skin. So there's some skin left behind, sort of thing. So it will regenerate. The question is how long. And so there's 2 reasons we reassess it. Different question to my burn assessment now. But the one reason is that the burn can extend. So sometimes the burn can get worse in the first couple of days. And secondly, that it can, we want to see whether it's showing like it might be a goer for healing in the first couple of weeks or not. And if not, we might do a graft earlier to get a better cosmetic result with a graft rather than leaving it to heal. But basically speaking, that is the difference between a hypertrophic and a keloid scar. Keloid scar is a worse thing, which tends to be stable, doesn't tend to get better, and is a lot bigger than the original scar. Hypertrophic scar isn't quite as bad, is often self-limiting, will often get better within 18 months, and is usually or often due to a delay in healing of the wound. So in fact, if you have got a delay in healing of your wound, if there's a reason for the scar becoming lumpy, that would lend us to maybe be more inclined to treat it with surgery, because one of the problems with keloid and hypertrophic scarring is that we don't really want to do surgery on patients with this sort of scarring, because we worry that by doing surgery, we're going to cause the same sort of scarring. So it is a difficult problem to treat, and surgery is usually quite down the line for things in terms of the modalities of treatment. We would usually do things like massage, moisturized massage. You do it at all scars, pressure, if appropriate, if you can get pressure on. Not always possible to get pressure on, but if it's on your breast, sometimes a bra strap can actually, a wire can actually be good if you've got a keloid or a hypertrophic scar in that area. Ears, we can get pressure clips. Sometimes burns and things, bad burns, you can get pressure for the dressings made for the faces, but it's quite hard to get pressure on certain areas. So other modalities are things like silicone, which can come as a strip or a gel. Steroid injections is a very helpful thing, often with the itch. They're often quite itchy. So we usually try these things prior to doing surgery, because we worry about by causing another scar, you're going to get another hypertrophic or keloid scar. So we would do other things first. If we can get away without doing surgery, we will. And it's something to be aware of. Particularly if you've got a history of keloid scarring and things, you've got to be aware of that and basically avoid surgery if you can. Why can't we offer removal of a hemangioma? I don't know. I'm not sure whether I just get a list of these questions. So I'm not sure the background of that question. Because we can, on paper, I got a couple of reasons why we might not be able to offer it. The first reason is that it's often children, and we can't operate on children. So hemangiomas usually, always basically will affect children. It's a vascular anomaly. It's a problem with the blood vessels causing red areas. So we can. So they're usually involving children. We can't operate on children at the clinic just because of the CQC and the guidelines and the policies, etc. So we don't operate on children at the clinic. So that's one reason. The other reason might be that they usually get better on their own, hemangiomas. certainly in the young people, there'd be a very limited indication to do something. It's only if it's causing a problem. So if it's obstructing your eye or your nose or your mouth or your anus or something that's obstructing somewhere, you might want to do some treatment to it. But the vast majority, I think, remembering going back to my exam, I think it's something like 70% at 7 years will involute. So they will go away, basically. So the majority of hemangiomas will go away. Having said that, so when it gets to adulthood, it's unlikely to have a hemangioma in an adult. Having said that, when they involute, they often leave a bit of baggy skin and a bit of wrinkly skin of where they used to be. So it might be that someone would want that to be removed. And we could certainly do that. So we can offer removal of that excess skin, but as I say, hemangiomas usually will get better on their own and only need treatment if they're obstructing an orifice or causing a problem like that. So I guess that's why. So it's not like we can't offer it. It's just, well, we can't if it's a child, but we often don't need to do anything about them. Do we offer hernia and muscle repair with a tummy tuck? Muscle repair, yes. So muscle repair, they call it muscle repair, but the muscles are often a bit splayed with a tummy tuck. They're often a bit pulled apart, the rectus abdominis muscles. So bringing those back together is an integral part of the tummy tuck. So yes, that is definitely a doable thing and standard part of the tummy tuck. You don't have to ask for it. You don't have to ask to have your muscles repaired. A hernia repair is a little bit different, because I saw someone the other day who had an incisional hernia. She had quite a big hernia, and she was on the waiting list for the NHS. And I said, actually, you know what? I would probably get that done on the NHS first, because that might need a mesh repair, and that will probably need a general surgeon to repair that. So when it comes into putting in meshes and what have you, personally, I don't want to speak for all plastic surgeons. Personally, I wouldn't get involved with that. I would let a general surgeon do that, who would be used to repairing hernias of the abdominal wall. Having said that, sometimes you notice tiny little hernias when you're doing a tummy tuck, usually around the belly button, like little ones, which you can literally just stitch closed. So that can sometimes be noticed pre-op. Sometimes you don't even notice it pre-op, and you find it as an incidental finding. So if you find a small one as an incidental finding, we will repair it, no problem at all. But if you've got a big one, we would not, I would not get involved with it, and I would get an opinion from a general surgeon and probably suggest that you get it repaired prior to having your tummy tuck. Do we offer skin cancer removal? Nice. Yes, for sure. And I think there's going to be a big push for the private sector to help the NHS, really, because the NHS waiting lists are big, and so, for things like this, so the skin cancers are removed by the NHS, and they do a very good job of that, and that's sort of been the mainstay. So it's not a huge part of our work, to be honest with you, skin cancer removal. However, we've done a few, and we would do them absolutely fine. The only thing is, it's a little bit more involved than, for instance, having a mole removed, because if you get an incomplete excision, you might have to have it another excision, and often, pretty much always with the skin cancer, you have to take a rim of normal skin from around it. So they're often bigger operations than, for instance, a mole removal. So it's a bigger operation than a mole removal, but certainly all the plastic surgeons, and actually Azam Faroa at the clinic specializes in skin. So he, in the NHS, does all the skin cancers. So, we're completely able to do skin cancer removal, and obviously we've got the minor operating suite and what have you. So we can do it. It had to be discussed at an MDT, so we need which is a multidisciplinary team. So, we would need to access that. But we certainly have and can do skin cancer removal at the clinic. I have a heart condition, and my cardiologist has advised me I can have breast augmentation through twilight anaesthesia. Is this possible? Absolutely yes. I'm not a cardiologist, so I don't. And if that's what the cardiologist says, I would say fine. But my mind is saying I'm not an anaesthetist either. You know, is twilight anesthetic less cardiac intensive than general anesthetic? Because what we don't want is you getting stressed out. Basically, if you're fine with it and relaxed with it, absolutely fine. And for a breast augmentation, twilight anesthetic is completely fine. It's local anesthetic with sedation, and it's completely acceptable and you know, a very well tolerated and accepted way of doing a breast augmentation. You know, if they're under the muscle, a little bit more difficult. If you've got an asymmetry, a little bit more difficult because we've got to inject local anesthetic in. So there are a couple of things that we have to possibly have to work around. But on paper, breast augmentation under twilight, no problem at all. And if that's what your cardiologist has advised, absolutely fine. We would have to speak to the anaesthetist to check they're happy. It depends on what heart condition is, but it's very reassuring that your cardiologist is giving you the go ahead because they know what your problem is and what's what. So do you know what? I think I had quite a lot of questions because I haven't been here for 2 weeks, and I think what they did is they split them off some for next week. But a little bit quiet in here today, but anyway, perhaps I should have done the ones for next week, but yeah, no, hey, it's fine. Listen, that's been the Facebook, Instagram, YouTube, Facebook, how the YouTube, Instagram, Facebook, YIF, IYF. Anyway, that's been the live. To call it the Facebook Live, but it's the Facebook, Instagram, YouTube Live. If you have any questions, post them down below, as it were. Don't know if you can do it. Can you do that on Instagram? Facebook, you can. YouTube, you can. And I'll do them next week, presuming everything normal next week. I think it is. If you don't have any questions and just want to join in and sit there, then that's always very gratefully received. So what I'm going to do now is I'm going to check out, put my feet up, and bid you good night. Thank you for joining me, and have a good evening.